and welcome back to the Gluten Free RN podcast. I'm Nadine the Gluten Free RN. Today, during episode 49, we are going to discuss Lyme disease and celiac disease with Dr. Usha Honeyman. Stay tuned. Hi, and welcome back to the Gluten Free RN podcast. Today, I have the distinct pleasure of interviewing Usha Honeyman, who is a naturopathic physician and also a chiropractor. She practices in Corvallis, Oregon, and sees many patients with Lyme. She's actually a Lyme expert in the state of Oregon. Thank you for being interviewed today, Usha. You're my very first interviewee.
That's awesome.
I know. I'm so happy you're doing this. So today we're going to talk about Lyme disease and the overlap with celiac disease. And Usha, being an expert in Lyme disease, is going to give us a lot of great up-to-date information on Lyme disease, how to treat it, what to look for, and maybe if you're on a gluten-free diet or a paleo diet and you're still having symptoms like neurological symptoms and they're cyclic, then maybe you need to get tested for Lyme. So we'll talk all about Lyme during this episode 49 of the Gluten Free RN podcast. I'm going to let Usha introduce herself officially, and we'll get started on this very interesting topic.
As Nadine said, my name is Usha Honeyman, and I have been practicing in Corvallis, Oregon for 30 years now. I'm dual licensed as a chiropractor and a naturopathic physician. I got introduced to treating Lyme disease. It was kind of an interesting story. When I got my naturopathic license, I had two patients in the same day come in and tell me I have Lyme disease and I need antibiotics. And I'm like, oh, maybe I need to learn something about this. So it just took off from there. I really enjoy treating Lyme disease. I love it because it's so dang complicated, which is part of what is so distressing for patients. But I hate to say it, but it's really fun for me to treat it. So with climate change and global warming, we've got an increased range for these insects. With the winters not getting as cold, the fleas aren't getting killed off during the winter. Fleas, mosquitoes, and ticks, any insect that takes a blood meal and goes from one mammal to another can transmit these infections. And when I say infections, the Lyme bacteria is Borrelia burgdorferi. The term Lyme disease is an umbrella term for Lyme infection plus the organisms co-infections that people can get from the insect bite. So Borrelia burgdorferi is a spirochete. It lives in the insect as a spirochete. So when people first get infected, the spirochete is being transmitted from the insect to the person. Spirochete is a corkscrew-shaped bacteria that can basically screw itself through and into any tissue in the body. The other spirochete that infects human beings is Treponema pallidum, which is the causative organism for syphilis. And there are many similarities between the two infections because the two bacteria, Borrelia burgdorferi, which is the Lyme bacteria, and Treponema pallidum, have very similar behaviors when people get infected with them. The usual vector or insect transmitter of these infections is ticks, because ticks, when they bite us, their saliva disables our immune system at the site of the bite. So the other insects that could carry these pathogens, they don't have the ability to disable our immune system at the bite site the way ticks do. The Centers for Disease Control acknowledges that there are 30,000 new cases of Lyme disease in the United States every year. But at the same time, they say we are underreporting the incidence of Lyme disease in the United States by 90%. In other words, there are 10 times more new cases of Lyme disease in the United States every year, which brings the new incidence of Lyme disease to 300,000 a year.
Those are big numbers.
Yeah, it's kind of astounding. And then what I run into in my practice all the time, and if you as the listener have friends with Lyme disease, many times people go for a decade or more not being diagnosed with the infection. So when I think about those numbers of 300,000 new cases every year and many patients not being properly diagnosed for 10 years, it's absolutely astronomical how many people are probably walking around with these infections. So when I say infections, we've got Borrelia burgdorferi, which is the Lyme disease bacteria. but we also have co-infections. So those can be, there's Bartonella, there's Ehrlichia, there's Anaplasma, there's Babesia, and then there's some viruses. There's been some cases recently in the news of Powassan virus in upstate New York. So that's been reported to the health department. Powassan virus causes encephalitis, so swelling of the brain. It's potentially fatal. At this point, there's no treatment for it. Fortunately, for Lyme disease, for Borrelia burgdorferi, we do have treatment. So I hate giving people depressing news.
Well, it is depressing, but it's also good to be informed about all of these topics. You know, a lot of people have suffered for years with celiac disease and not known it. And so here we have another situation that maybe politically or maybe from other sources was kept from people, the media or whatever, prevented people from getting diagnosed correctly. And now we have a huge epidemic of people potentially with Lyme disease that need that information.
So as I implied, Lyme disease is the most common insect-borne disease in the United States. So it's transmitted from one mammal to another by insects that take a blood meal. So mosquitoes, fleas, biting flies. I even had a patient one time swear that he got Lyme disease from a spider bite, but primarily ticks. The main reservoir of the bacteria is deer. As one of my patients says, they're just giant, tall rodents. So she's not a very good friend of deer, and I can see why.
You know, there was an interesting story, and I already knew about Lyme disease, so I know that I need to be careful when I go out in the woods. But my son had taken his dog down by the river one day, and he said, well, Mom, there were these bugs that were kind of jumping all over us. So we quick ran back to the truck. And when we got back to the truck, I realized they were all ticks that were covering the dog and myself. They were everywhere. And thankfully, he had a friend with him so that they could go over every inch of their skin, and I mean everywhere, to check and make sure that those ticks weren't adhered. And I said, Rory, that's really bad. And he said, I know, Mom. He has since gotten tested for Lyme disease and apparently at this point doesn't have it, thankfully, but we will continue to keep an eye on that.
Yeah, which that brings up a good point, because if you look at the Centers for Disease Control website, they will say that in order to transmit Lyme, the tick needs to be attached for 24 hours or some length of time. There are documented cases of Lyme being transmitted if you're in an environment where ticks are endemic, you want to make sure you're doing tick checks. And actually the best is to use some kind of insect repellent on either your clothing or your skin. There's picaridin and natropel DEET is kind of the traditional one, but the picaridin and natropel are made from, I think, a tomato extract, so it's non-toxic to us, and those are effective. And then there's a insect shield. You can get clothing in travel stores that's treated with insect shield, and that's an effective insect repellent for the areas of your skin covered by the clothing. The information we get, if you look on the internet, you're going to find conflicting information about Lyme disease. And that's because in the United States, we have a political controversy in medicine. So it has everything to do with politics and power and nothing to do with the science of the infection. The Infectious Disease Society of America, they have a set of guidelines that basically says Lyme is a easily cured, short-lived infection. So their guidelines were established in the 1990s before we understood a lot of the scientific information about how the bacteria behaves. It's a very fastidious bacteria, so it's very difficult to culture it in the lab and to observe its behavior. And it actually took quite a while from the time that the infection was enumerated until the bacteria was actually discovered, and even longer after that to figure out how to actually study it in a lab without just losing the culture. So the IDSA guidelines haven't been updated, and they're really honestly not a benefit to the public. The people controlling the IDSA Lyme guidelines have a vested interest in the development of a vaccination for Lyme, which was on the market for a few years in the 1990s and then withdrawn because it caused arthritis.
Oh, is that not also an overlap with celiac disease? We have the same issue, is that people aren't getting diagnosed because some of the celiac specialists are looking for a pill or a vaccine or some type of thing they can sell before they actually tell people they have celiac disease. Not good.
Amen.
So the interesting thing about Lyme is that the patients have to be on long-term antibiotics. And one thing I, as a nurse and as a person with celiac that is trying to really build up people's immune system and their microbiome, here we have a situation where people have to take long-term antibiotics. They really do have to take long-term antibiotics. Can you talk about that a little bit?
Yeah. So, and I get asked about this a lot by patients, but so antibiotics only kill bacteria when they're going through their replication phase. So when the bacteria are not replicating, the bug and the drug happily coexist. There's no killing happening. So I always use the comparison of pneumonia. So a 10-day antibiotic prescription for pneumonia, the bacteria reproduce every 20 minutes. That's 3 times an hour, 72 times in a day. In 10 days, the bacteria, you're getting 720 replication phases of the bacteria, which equates with 720 chances to kill the bacteria. When we're talking about Lyme disease and the co-infections, these organisms reproduce once a day or once every 2 days. So to make the math easy, I always just talk about once a day. In our pneumonia example, we had 720 replication phases of the bacteria. If we have an organism that in 10 days for pneumonia, 720 replication phases. An organism that reproduces once a day, if we want to get 720 replication phases, we need 720 days of antibiotic to get the same killing effect, which is 2 years.
Whoa. That's a long time to be on antibiotics. But these little buggers are tenacious.
Yeah, definitely.
Are some of the spirochetes more tenacious than others, or are they all just that they're going to replicate once a day? Are there variations of that, or are they all very...
Well, I don't know. I don't have any references for it, but I'm guessing just based on what I have read and what I hear from patients is that depending on the tissue where the spirochete lives, because remember, it can travel anywhere in the body. So depending on the tissue each spirochete is living in, or the environment, or even the temperature of the certain body part, the bacteria might be reproducing, once a day or maybe every other day. Another thing that these bacteria like to do is they like to hide in places that don't get a good oxygen supply.
Ooh.
Yeah.
Oh, they're anaerobes?
Yeah, they prefer to be anaerobes. They lower body temperature. So this bacteria has 21 plasmids, which makes it 3 times more complicated than any other pathogen known to infect human beings. That's triple the amount of genetic material of any other bacterial pathogen, which makes it really, really sneaky and really, really smart.
Do you think they're smarter than we are? Some of us humans.
I think maybe they are, actually. I think maybe they are. When it manipulates body temperature, it likes a colder environment. And it likes to be anaerobic, so it hides deep in connective tissue where it doesn't get a good blood supply. But as we know, human beings mount a fever in order to fight infection because fever makes white blood cells work faster. When the Lyme bacteria manipulates our neuroendocrine system to make us colder, it also slows down the white blood cell response. So one of the big things that antibiotics do in these infections is create some dead bacteria. The dead bacteria actually wake up the immune system. When you have living bacteria, they do so many different things that I can't even remember all the things they do. But one of the things that these bacteria can do, when the immune system is tagged on a specific outer surface protein that white blood cells then can grab onto and bust up the bacteria, the bacteria will actually, with quorum sensing, they will all take that specific protein and hide it inside and display a different protein on their surface. So then the immune system thinks, oh, that protein is gone, therefore I killed off that pathogen, which is not the truth. So when we use antibiotics, and I often don't use very high doses of antibiotics with my Lyme patients, I just want to create some dead bacteria because the dead bacteria can no longer manipulate the immune system. And the dead bacteria are providing information to the immune system, to the white blood cells. I kind of picture dogs in a dog park like a new dog comes in, which is the dead Borrelia, and all the other dogs are sniffing it. Mm-hmm. That's basically how I visualize what's happening. Like you've got this dead Borrelia, and so these white blood cells are like, hey, what the heck is this? We didn't know this was here.
So they attack it, or they just, is that part of your adaptive immune system?
They're reading it. The white blood cells are reading it.
So it would be part of the adaptive type. Okay.
I guess.
Oh, okay. So talk more about the body temperature and how you advise patients to raise their body temperature in order to fight this bacteria.
If our average body temperature is below 98.0, which a lot of times women, their average temperature is below 98.0, the enzymes in our cells and our cellular behavior, it's sort of like if you're trying to cook something and your stovetop won't turn on or your oven won't get hot enough, the food doesn't get properly cooked.
Good analogy. I like that one.
It's pretty darn accurate. Yeah. So, like, if you think about it, millions of reactions are happening inside the cells in our body all the time. And they're chemical reactions that are temperature dependent. So if the temperature is too low, all the reactions get slower. What I started studying about thyroid medication, specifically liothyronine, which is also known as T3. Mm-hmm. And when you give T3, it's one of the few ways that you can actually raise body temperature. And what I found in my Lyme patients is if they had hypothermia, which is officially a temperature below 98.0. So if they have hypothermia and I give T3 and we can bring their body temperature up, their white blood cells are now going to work more efficiently. You know, I think of it like the white blood cells were running through a swamp and now we picked them up and put them on a running track and now they can do their job. Nice. So, yeah. And what I found when I started using the liothyronine or T3 with my Lyme patients is we needed less antibiotic because we're getting the white blood cells to work more efficiently.
That's brilliant.
Thank you.
Very good.
When people have a low body temperature, there's lots of other things that feel crummy. So the T3 helps them poop better. It helps their sleep. It helps lots of things. And a lot of times people with chronic low thyroid function have chronic constipation, and there's nothing else that will help their constipation until you try T3.
Okay. See how there's a lot of overlap here with celiac disease. And we're going to talk a little bit about why people that have Lyme disease are advised to also be on a gluten-free diet. Can you do that, Usha?
Yeah. These infections cause inflammation throughout the body. And one of those principal locations is the lining of the intestines. I'm going to digress a little bit and talk about Bartonella, which is one of the Lyme co-infections. Bartonella likes to live in the lining of the stomach and intestines, and it actually forms abscesses in the lining of the intestines. So some of my patients are hesitant to take antibiotics at all. And I explain to them, look, if you have an infection that's causing abscesses of the lining of your intestine, you need an antibiotic. Like no amount of probiotic is going to get rid of those abscesses. You have to kill off the bacteria that's growing there. And I've found even in patients who don't have Bartonella, a lot of times Lyme patients will have ulcerative colitis, microcolitis, different forms of inflammation of the gut. And they're justifiably hesitant about starting antibiotics. But what they often will come back and say is their gut is doing so much better since I put them on antibiotics. Along with that, I always make my patients take good quality probiotics. The primary reason for that is to prevent overgrowth of antibiotic-resistant Clostridium difficile. For listeners who don't have Lyme disease, if you look at the prescribing guidelines for even short courses of antibiotics, the prescribing guidelines recommend probiotics to prevent overgrowth of C. diff. Even if you're only taking the antibiotics for 4 days or 10 days or something, you always should be taking probiotics. So we as practitioners should be prescribing probiotics along with any course of antibiotic.
Excellent point. So can you talk a little bit about the neurological components and what happens when these spirochetes actually invade the neurological system, which we all know the intestines are their own neurological system, the enteric nervous system. Plus we have the brain. Can these spirochetes actually cross the blood-brain barrier?
Oh, yes, for sure. Yes, the spirochetes do infect the brain. They infect the spinal cord. There's a characteristic low-grade meningitis or meningoencephalitis that Lyme patients often will describe. So they'll say, my neck doesn't really hurt, but it's just stiff all the time. And they'll kind of point to the top of their shoulder blades and the back of their skull and say, it's just from here to here. It's just really, really stiff as a board all the time. And then they'll say, I kind of get this dull headache most of the time in the back of their head. And basically what they're describing is a low-grade meningitis that's being caused by the Lyme spirochete irritating the meninges and basically their brain and spinal cord. It's really, really common for Lyme patients to have really bad brain fog, like they can lose much of their cognitive ability. I had a patient a few weeks ago who had to stop driving because her brain couldn't pay attention. If you think about what driving requires, you're controlling the car, but you also have to pay attention to everything that's around you. And her brain no longer could cope with all of those tasks simultaneously. So she had to stop driving. She has to have somebody else take her wherever she needs to go. It's really, really common that Lyme patients will have ataxia, so some balance trouble. Vertigo, dizziness is a little less common than the ataxia. I ask people, how's your balance? And they'll say, fine. And I say, so do you bump into things like when you're going through a doorway? And they go, oh yeah, I do that all the time. Well, that's basically a balance problem. They often will have trouble with word finding. That's very, very common, is they can't always think of the word that they're trying to say. And then reading comprehension is another common problem. They also can have any kind of sensory problem. So people will have itching skin or numbness or shooting or burning pain. Often the neurological symptoms like that, the sensory abnormalities are migratory. So, they'll have stabbing pain in one arm, and then a few hours later, it'll be in the opposite leg or that kind of thing. They can develop weakness. I've got, Lyme patients sometimes lose the ability to walk. When you think about all the different things our brain does, and you've got this corkscrew-shaped bacteria traveling through the brain, setting up housekeeping, pretty early on, I realized that the image that came to me is like, okay, this infection is turning this person's brain into Swiss cheese. And I'll tease my patients. I'll say, I don't really care that much if your joints hurt, but when your brain doesn't work, I really care. Like, I want to keep your brain working.
Yeah, ideally, we all want to keep our brain working. So you mentioned Swiss cheese. Is this something that can be seen on a head CT or an MRI? Or what type of testing would people need to get done?
So the testing area is controversial as far as confirming whether people have a Lyme diagnosis. And laboratory testing for Lyme is one of the reasons that we have that discrepancy between the CDC acknowledges we have 30,000 confirmed cases of Lyme every year and 300,000, 10 times that, of cases happening that are not being diagnosed. But to answer your question about imaging, yes, there's a characteristic appearance of the brain when people have an MRI. So usually the radiologist will say something like white matter changes not consistent with MS or possibly MS, something like that. So there's a characteristic phrase that radiologists will often say when they read the MRI. And I don't usually look at the MRIs because I don't know how to read them. But when I see that sentence in the report and the patient has been told, oh, hey, maybe you have MS, I'm like, no, this is probably Lyme. I mean, this isn't exactly answering the question you asked, but when I'm talking to a patient who's got a potential diagnosis of MS, so that's an incurable disease, it's really expensive to treat, and the conventional treatment only slows down the progress of the disease, versus me saying, hey, if this is Lyme, the risk of giving you an antibiotic that you may not need pales in comparison to the risk of leaving this infection untreated. In other words, I've got many, many patients over the years where their neurological manifestations that had been diagnosed with MS or might have been diagnosed with MS if left untreated get almost entirely reversed.
Wow.
So, yeah.
That's remarkable in the fact that a lot of people are diagnosed with Parkinson's and ALS and MS, and really all that's offered to them is treatments, but no cures or anything. So here we have a situation where people might actually get better.
Yes, exactly. And when we're talking about things like Parkinson's, ALS, and MS, elimination of gluten is really, really important. I'm sure you've talked on your podcast about I can never remember his first name, but Perlmutter's book, Grain Brain.
Mm-hmm.
So his premise is, hey, as a neurologist, I don't have cures for these diseases. So whatever I have to offer patients is not going to cure them. But if I can get them to stop eating gluten and reducing the percentage of carbohydrates in their diet, they have a possibility of becoming cured.
Yes. That's the crazy thing, is that it's either high dose medications and not getting better, or changing your diet and potentially being on antibiotics for a period of time, and people actually get better. Isn't that the beauty of it?
Yeah. When I have new patients and I tell them, like I had a young fellow this week who he had to drop out of high school. He was a straight A student and he can't effectively do his coursework anymore because he has so much fatigue and so much brain fog. I can confidently say to him, hey, if you have Lyme disease and we put you on antibiotics, we can reverse all of this and you can get back to your previous healthy state of being.
Wow. I see more and more young people with very serious neurological issues, or they can't be in school because of health issues that are not being addressed. And here we have, again, a situation where, either a diet change and or antibiotics might completely restore their health.
Yes. So then the question is the gut microbiome. You can draw conclusions from what I already said, that if people have an infection, we can't treat it with probiotics. The immune system is unable to mount an effective response because of all the manipulation that the Lyme bacteria has done to their immune system. We need to use antibiotics. Nadine can probably talk better about the gut microenvironment than I can, but I always want my patients on a good quality probiotic, not just for preventing C. diff, but because 75% of the immune system is located in the intestines. And we need to support that immune system by putting in beneficial bacteria as we kill off the pathogenic bacteria. And I always want my Lyme patients on at least a month of probiotic after they finish their antibiotic.
Right. So those probiotics are very important. And, we have to deal with things like small intestinal bacteria overgrowth or opportunistic infections if we're not using probiotics appropriately. So it's extremely important to work with somebody that actually, number one, knows about Lyme disease, knows about gut health, and can help you restore your intestines to the optimal health that they deserve, because it's all about the gut.
So I think I already said, if I didn't, I'm going to say it again, that when we're treating Lyme disease, I want my patients to stop consuming gluten because gluten causes inflammation of the gut and these infections cause inflammation of the gut. You can't have an inflamed, infected gut and have the immune system be happy and healthy. That's not going to happen.
And not only that, but celiac disease causes leaky gut or increased permeability of the intestinal wall, perhaps allowing these spirochetes to have better access, not just to the intestinal wall in our bloodstream, but every cell in our body is affected by gluten. So it's very important that we actually build up our immune system and make sure that our cell walls are intact also.
So I'm going to talk about the alpha-gal reaction, okay?
Oh, yeah, go ahead.
Okay.
Do that.
So this is kind of an obscure fact, as a friend of mine used to say, an obscure fact to know and tell. It's called the alpha-gal reaction, and it's an anaphylactic reaction to beef. The Borrelia bacteria, the Lyme bacteria, has regional variation. So there's different strains around the world. There's different strains in North America. So the strain of Borrelia, which I have to talk about this again when we talk about lab testing, but the strain of Borrelia that's in the northeastern U.S. is different than the southeast, is different than the upper Midwest, is different than the mountain west, and is different than west of the Rockies. So we have different strains of Lyme disease all over. They're all Borrelia burgdorferi, but they're different strains of Borrelia burgdorferi. There are also other Borrelia organisms that have been discovered, like Borrelia miyamotoi is present in the United States, and it causes a relapsing fever type illness, which the symptoms seem like malaria, but it's not. It's Borrelia. It's a Lyme bacteria. Fortunately for us, the treatment for all these different Borrelia bacteria is basically the same. It's the same set of antibiotics, which I'll get into in a bit. But anyway, to get back to the alpha-gal reactions. So in the southeastern U.S., whatever strain of Borrelia lives there have been a handful of cases of people who have steak for dinner And about 4 or 5 hours later, so they've gone to bed and they wake up and they're having an anaphylactic reaction in the middle of the night, which kind of baffles the emergency room doctors because their spouse will take them to the emergency room to figure out what the heck happened. And it's like, well, you were sleeping. This couldn't be an anaphylactic reaction because anaphylaxis happens like immediately. They finally traced it back to people who had beef for dinner. They developed several hours later, they have this anaphylactic reaction, and it turned out to be people who had Lyme disease. They had an infection with the Borrelia spirochete, and they were developing this allergy to beef. So I don't want to scare people away from eating beef, but on the other hand, this is sort of, like I said, an interesting fact to know and tell, that these alpha-gal reactions.
That is a fascinating story. It's very localized, apparently, but just something for people to be aware of, that these spirochetes are so interesting. Oh, and I have another question. Is it possible that the beef is... Never mind. I don't even want to go there.
You mean that the animal has the infection?
Yeah.
Well, we've wondered that because sometimes people who are hunters will bring their kill back. I'm a vegetarian, so I'm not up with all the lingo. But anyway, so they bring back the deer or bear or whatever, something that has a Lyme infection. And if they undercook it, we were wondering, like, could they get Lyme that way?
Yeah.
It's not that likely because in general, although you make me wonder, in general, the Lyme bacteria, when we ingest it, that's not a very good way to actually get the infection.
Okay.
I think it's because of the digestive juices, because the bacteria is not very hardy.
Okay.
And this is really controversial. So I'm going to segue into something controversial about transmission. There is significant evidence, although it hasn't been published, that the Lyme bacteria can be sexually transmitted. And also, we suspect that it's transmitted from mother to fetus at about the same rate as HIV. So infected mom, there's about a 30% chance that her baby will contract the infection. If you watch the movie Under Our Skin, Alan McDonald is a pathologist who worked on Long Island in the 1980s after the Lyme bacteria had been discovered. And he took babies who were stillborn and looked at their tissue samples for the Lyme bacteria. So these are newborn babies who died in utero. So they had no chance of having been bitten by a tick or a flea, and they had Lyme disease in their tissues, the Borrelia spirochete.
Yeah, I actually think we have a case of that here where the mom actually transmitted Lyme disease to her baby, and that wasn't found until they went back to Connecticut and were actually tested in Connecticut and seen by a doctor there. And they have been seen all over the country by different doctors, and that's where they got diagnosed correctly. And it was that situation where the mom had transmitted the spirochete unknowingly, of course. And so do you find that these people walk a little different, not only with especially the children? I seem to remember that these children have a little bit of a toe gait, or there's something interesting about their gait.
Honestly, I don't see that many kids with Lyme because it depends on the parents to bring them in. So I couldn't comment on that. So yes, adults will have all manner of strange gaits when they have Lyme disease. Not everybody does, but when I see it, it's almost like there's slowed transmission from the brain to the nerves of the lower extremities or the nerves of their hands. So there'll be a lot of times abnormal movements of their extremities, their legs and their hands. And the other thing that even if a patient doesn't come in here thinking they have Lyme, but when I watch them talking and answering my questions, there's an odd way that they move their lower face. What it seems like to me is they're having a great deal of difficulty controlling the muscles of their tongue and their lips and their mouth to actually enunciate words clearly. For me, that's like a bingo. Oh, this person has Lyme. When we're talking about that, so CDC says on their website, if people have a history of Bell's palsy, which is paralysis of the facial muscles, or trigeminal neuralgia, which is the sensory nerves that supply the face having severe pain, both of those things are red flags for Lyme disease.
Wow. This is great information for, I'm sure, people all over the world, not just here in Corvallis, Oregon. If people literally all over the world have to worry about this or have to at least be aware of it, where would you send them to find information that's reliable and helpful to them?
Probably the best place to start. I know there's good websites run by the public, by patients who've recovered, and I can't remember their names. Sorry. So the place to start is the website of the International Lyme Associated Disease Society, which spells ILADS, ILADS.org. And they have an informative website. I get a lot of patients who come to me because they basically tracked me down through ILADS. I'm not sure if they have a physician reference there or if people have to call the office or if there may be in your region where you live, if you have a Lyme support group, like we have one in Bend, Oregon. So patients contact them and then get referred. When we talk about testing and treatment, that's where having a Lyme literate doctor becomes really, really important. For example, so in a research setting, we can take the Lyme rash, which I didn't talk about the rashes, but 50% of the people who have Lyme disease get a rash. The other 50% have Lyme disease and never got a rash at the site of the insect bite. And because ticks in the springtime, the nymphal ticks bite and fall off, so you don't know you got a bite. And if you don't get a rash, you have no idea you got this infection. And all of a sudden you have like flu-like illness with aches and pains that stays around for a couple of weeks and then mysteriously goes away. And then your health takes a nosedive the years after that. You wouldn't understand you got Lyme disease because you didn't see the insect and you didn't get any rash from the bite. Anyway, going back to what I was talking about with laboratory testing, in research settings, we don't have this available clinically. They can actually take a skin scraping of the Lyme rash and culture out Borrelia organisms in the lab. So that proves that the patient has Lyme disease because they found the organisms in the culture.
Is that pretty superficial? Is that a superficial skin scraping? How do they get that out of the skin?
I don't know for sure. I'm imagining it's a scraping because the rash is the target lesion, right?
Mm-hmm.
And so what's happening there is the Lyme bacteria is spreading out from the site of the bite and causing inflammation. The immune cells in the skin are reacting to the presence of that bacteria as it travels away from the site of the bite. And so usually the rash, if it's present, will gradually expand. And it doesn't have to be a target lesion. I've seen many Lyme patients, their rash will be a solid lesion. Often it's round, but I've even seen, like I had a patient with a trapezoidal Lyme lesion. So it just kind of depends on the ecosystem and what's happening in the skin. But anyway, in these patients where they proved, because they cultured Lyme Borrelia from their skin, they proved that they had the bacteria. 50% of them fail the laboratory testing.
Oh.
Yeah. So, I mean, I could tell patients we might as well just toss a coin to figure out if you have Lyme disease, because that's about as accurate as the tests are. In the United States, the standard testing is what we call a 2-tier testing. So we do a screen, which is the ELISA test for the Lyme bacteria.
Mm-hmm.
And then if that's positive, we do what's called reflex to a Western blot for the Lyme bacteria. So a Lyme Western blot. How I explain it to patients is because so many people who actually have the infection fail the screen test, what we've done is make the holes in our screen way too big. When I did my internship, I worked in a clinic where we were testing people for sexually transmitted infections, one of them being HIV. So when we did the test for HIV, if the screen test came back positive, we had to tell the patient, look, this doesn't mean you have HIV. We just don't want to miss anyone. So we have to do the Western blot for HIV to confirm that you actually have the infection. In Lyme, it's the opposite. We're missing, with the screen test, I'm guessing 80 to 90% of the patients with our screen test. The people who actually have the infection never get reflex to a Western blot. The other issue with Western blot testing in the United States is that if you get a Western blot test at your local lab, the kit that they use for that is a Lyme bacteria that's been living in a laboratory on Long Island. So it was originally from Long Island, and it's been living in that laboratory since the 1980s. So number one, it's lost its antigenicity. But number two, if you got bitten by a tick anywhere else in the United States or somewhere else, it's likely to be negative anyway, because the tick you got bitten by was carrying a different strain of Borrelia.
Wow. That's a fairly big false negative range.
Mm-hmm.
And so what do you do? Do you assume? How do you find these people?
Okay. So first of all, when I do the screen test, I want a test that's going to give me a quantitative value. Some
What
labs,
does quantitative mean?
that means if it doesn't flag at 1.0, they'll give me a number below 1.0. So then when that comes back and it's technically negative, but I have evidence on paper that the person's immune system is reacting to this bacteria, I can say to the patient, look, there's evidence your immune system is reacting to this bacteria. Therefore, you probably have the infection. I'm almost certain you have the infection, but this test is not reportable to the health department. So bingo, we have a case of a patient with Lyme, and almost invariably I put them on antibiotics and they get better.
Okay.
So if they have a test with evidence of the bacteria, we put them on an antibiotic and their neurological symptoms and their fatigue and all that gets better. Then with 20/20 hindsight, it's like if they had Lyme or didn't have Lyme, they had something that they needed an antibiotic for.
That's amazing. And the other thing too is what happens if you don't treat Lyme? What happens in the end result if, the Lyme goes untreated and these poor people have no treatment options, period, or they just what happens?
Well, the short answer is they're probably going to end up on disability. They have chronic pain. They have chronic fatigue. They have brain fog. They have trouble with comprehension, trouble with basically functioning in their life.
Can Lyme actually kill people? Is it something that will lead some people to die?
Yeah. My first year in practice, I had a patient who was diagnosed with ALS. When she came in and I got her history, she had about 20 years prior, she had what we call disseminated borreliosis. So basically the bacteria had traveled throughout her body and she had these red disc-shaped lesions all over her legs. She went to more than one dermatologist and they were like, well, they don't hurt. They don't itch. We could give you a corticosteroid, but, don't worry about it. Then she gets diagnosed with ALS 20 years later. And when she told me about these rashes, I'm like, I want to say a curse word, but I can't, right? I'm like, holy blank bleep. It's like this woman has Lyme disease because you don't get those kind of characteristic Lyme rashes that show up in multiple locations. So the Lyme rash will be at the site of the bite. Mm-hmm. That's normal. But when people start getting Lyme rashes in other locations, it's because the Borrelia spirochete has traveled everywhere and it's often using the nerves. So when people get the embryologic connection between the skin and the nervous system, so when people get disseminated borreliosis, which is those Lyme rashes all over, they also have it in their nervous system, which was the case with this woman. She decided to go with the neurologist's advice for ALS. I got a call from a friend of hers about 6 months later. She had passed away. So she chose not to treat the infection. That was my first year of treating Lyme patients. And it was very, very difficult for me because I realized that, hey, you can't really fool around with this infection because people can die from it.
How old was she?
She was probably 50. She might have been
50. I'm 51. But that's really young. That's extremely young.
Yeah. Yeah. Honestly, I don't know. I've had patients with MS that it was being caused by Lyme. I definitely have seen that. I suspect that a lot of people with Parkinson's, Lyme is either the cause or a significant contributor. And I expect the same thing for ALS, but I haven't had that experience. And the sad thing about ALS is that from diagnosis, they have like a 6-month life expectancy from the time they get diagnosed with ALS. So in that woman's case, like if a Lyme literate doctor had seen her rashes 20 years prior, they could have treated her and she probably never would have gotten ALS.
Or suffered.
Right, exactly.
I'm sure she had a lot of suffering that went along with that.
Yeah, she had a long, slow decline before she got diagnosed with ALS.
Wow.
Yeah.
So tell us a happy story so that we can end this fabulous, very informative podcast on a really good note. Tell us about a person that got better.
Well, I have lots of patients who got better.
That's good.
Let me think of someone so I can tell their story. The trouble with being a physician is you fret about the people who aren't doing well.
Yes.
And when people get better and go away, it's like, oh, they're off my plate. I don't have to worry about them anymore.
Yeah, I would say the same is true for any medical professional. When people get better, it's, but you always remember the people that don't necessarily get better. And it's troublesome.
Yeah. Yeah. I had to get used to gritting my teeth at night when I first started working. I'd wake up with my jaw sore from fretting about patients in my sleep.
Yes.
Well, this one young fellow, he was pretty much debilitated by Lyme. He had seen another doctor who did a lot of his care, and he moved to Corvallis to go to school. So I was treating him. What he had was this funny combination of really bad neurological symptoms, but also like a OCD anxiety type thing that was, I think he had an underlying issue with that before he got Lyme, but the Lyme just made it really, really bad.
Okay.
I treated him for a couple of years, and he graduated from OSU, and I didn't see him again for a while, and he came back. So it was probably 2 years that I hadn't seen him, and he came back and he's like, oh yeah, I have some Lyme symptoms back again. I've been great for the last 2 years. So he had moved to California. He was working a job down there for a while, and then he moved back to Oregon for a job here. Not only did he was no longer like disabled, but he had finished college. He had worked a good job. He had another good job. And, he had a little bit of Lyme symptoms back. So I prescribed some antibiotics, because once people have had treatment, they know, oh, this one works well for me, or this one works well for me. And so I gave him one round of antibiotics, and I haven't seen him again. So I'm assuming he's doing great.
Awesome.
Yeah.
Oh, see, we all like it when people get better.
So I didn't talk about the forms of Borrelia. Do we have time?
Oh, yeah, of course. Go ahead.
All right.
Oh.
So there's the spirochete form. And then within about 2 months of initial infection, some of the spirochetes shed their cell wall and go inside of our cells. So being inside of our cells is another way that the bacteria hide from immune detection, because once they're inside our cells, the immune system can't see them anymore.
They are sneaky little buggers.
And then when the immune system starts attacking the spirochetes, some of them go dormant into, they call them cysts. And under the microscope in the lab, they look like just dust contamination on the media. For the duration of the infection, once you get past about 3 months from initial infection, you're always going to have spirochetes, intracellular, and cystic forms of Lyme. Some doctors will prescribe separate antibiotics for all three forms. My rationale is that it's really the spirochetes and the intracellular infection that are causing symptoms, because the cysts are dormant. If they're going to cause trouble, they're going to open back up into spirochetes. That's what we know from the laboratory evidence. So I usually just prescribe 2 antibiotics for Lyme disease, one for the spirochete form and an intracellular antibiotic for the intracellular form. And then if the cysts open up, they're going to be spirochetes. So as long as the patient is on a spirochete drug, that's going to take care of your cysts.
Oh, wow.
So the drugs for the spirochete are basically the same drugs we use for syphilis, which is going to be a penicillin, amoxicillin, a cephalosporin group of antibiotics. The intracellular is going to be something like your doxycycline or minocycline. And the Lyme treatment gets way more complicated than that, because if people have co-infections, these antibiotics don't necessarily kill their co-infections. And then depending on how good the spirochetes are at hiding, where there's not very much oxygen, then you may need to do other things to treat it.
I've said it before, but I'm going to say it again. Wow. That is a ton of information that we got today from Dr. Usha Honeyman. And it's all great. And it'll give a lot of people things to think about, especially if they still have, neurological symptoms or things that just aren't going away on a very specific, either gluten-free diet or a paleo type diet or whatever diet you're on to heal your intestines. If you still have neurological symptoms, this might be something that you want to investigate. And I cannot thank Dr. Honeyman enough for all of the information she gave to all of us today, not just, me, but everybody around the world for Lyme disease and the overlap with celiac disease. Thank you, Dr. Honeyman.
Well, thanks for listening. This was fun.
Oh, good. Okay. Thank you very much for joining us today for episode 49 of the Gluten Free RN podcast. I hope those of you that still have lingering neurological issues or are concerned about Lyme disease in any capacity have gained some very interesting insights today. It's been my pleasure to have the first interview for the Gluten Free RN podcast with Dr. Usha Honeyman, an expert on Lyme disease. Thank you very much for joining us, and until next episode, this is the Gluten Free RN signing off. Bye.